Hello, I'm Dr. John Kruse, and this is a live Q&A focusing on the videos that I released in the last week. I may have messed something up because I thought there was a live stream set up ahead of time and I could not find it. So if other people are waiting in a different live stream, I hope they quickly figure out that I am here. One other announcement, I will be doing Q&As next week, Christmas Eve, and 2 weeks from now, I guess the day before New Year's Eve, and at the same time. And second announcement is that Max, who's helping me from Paris, has set up a subreddit. So if you have questions or answers, hopefully that will be a better repository for them than having questions being deleted from the comment section or hard to find here on YouTube. You're welcome to try to use that site or to keep posting questions on YouTube itself. So the 3 videos that were released in last week, the new one was on ADHD and menopause. And actually, it's maybe not quite on ADHD and menopause. So there are no, as of the end of 2024, there are no studies looking at individuals, women with ADHD before menopause, during perimenopause, and after menopause to see what changes may result. On the other hand, there's a pretty substantial and growing body of research on individuals who did not have any executive function ADHD symptoms before their menopausal years, and then during the perimenopause developed symptoms that are as severe and pervasive as those in full-blown ADHD. And again, these are preliminary studies, but studies indicate that hormonal therapy, atomoxetine, and Vyvanse may all be helpful in treating ADHD symptoms that are arising through menopausal changes. There's a plausible mechanism in that there is a wealth of estrogen receptors in the prefrontal cortex that regulate dopamine, essentially helping maintain higher dopamine levels and decreasing glutamate. So with decreasing estrogen during menopause, that may result in executive function and cognitive problems. The other 2 talks, sound was redone and released. One is on the stories we tell about norepinephrine and dopamine. So these are very closely structurally similar neurotransmitters. They are different. They're released by different groups of cells in this base of the brain and spread out and modify lots of systems throughout the brain. Numerically, and along with serotonin, these are all tiny, tiny systems representing less than 1% of the neurons in the brain. And one of the common ADHD simplifications is that the presence of dopamine decreases noise, and norepinephrine boosts the signal so that you're less likely to be distracted by other background information or noises. There may be a grain of truth to that, but I think we oversimplify things often when we're talking about dopamine and norepinephrine. And the third video that I released was on sleep apnea and ADHD. We know that, so sleep apnea is when you stop breathing in the middle of the night. Usually it's for multiple seconds at a time. That mini suffocation actually wakes people up and startles them awake, and then they resume breathing. That can happen dozens of times a night. The most common form of sleep apnea is called obstructive sleep apnea, where it's structures at the back of the throat or airway passageways that are collapsing. There's also a less common form where structures within the brain are not getting the right signals across to continue breathing. In either case, sleep deprivation caused by sleep apnea can cause a complete range of ADHD symptoms, and at least in some cases of adults and children where the sleep apnea was effectively treated, the ADHD symptoms went away. So that's the 3 videos. So I'm open to questions. They do not have to be on those topics. They can be on any ADHD or mental health topics. And there, I am seeing something coming in. We've also played with the sound settings, so if this is any better than usual or worse, if you've come in usually, let me know. So Harriet Louise asks, what is happening when stimulants are helping depression symptoms more, but executive functioning is all time low, but not depression related? At least it seems. I'm trying. I'm having trouble parsing what the question is asking. It's asking something about the interaction of depression, ADHD, or executive function problems, and stimulants. I mean, stimulants usually help with executive function problems. The growing evidence is they help in the setting of full-blown, legitimate neurodevelopmental ADHD from birth, but they also seem to help with ADHD symptoms that come on through COVID, that come on through brain trauma, that come on through um, menopause itself. So usually the response, the executive function improvement is dose dependent. So if you're on too low a dose, that isn't going to help. If it's too much, it can cause overstimulation, and that can also not help. So you have to be in the sweet spot. And certainly, so these medications, the stimulants, also have energy boosting effects, and they also have mood boosting effects. And someone can have different effects at different dosage ranges. So you could get benefits in one realm without necessarily getting effects across the board. So I don't know if that answered the question. So Bear Jobs, so I'm happy if Harriet Louise has a follow-up question or if I haven't touched on what she's really asking about, I'm happy to follow up on that. So Bear Jobs asks, what do you think of neuropsych testing? What can help you understand? So I do have a video on neuropsych testing. One of the big problems with neuropsych, so we have lots of very bright people have spent their careers developing very specific and narrow tests to test working memory, to test impulse inhibition, to test directing attention versus sustaining attention. So different executive functions, different cognitive functions. We have fairly precise neuro tests, which have some validity in assessing these abilities of the brain. However, one of the things that happens in real life is very, very consistently across the ADHD literature or across when looking at executive function problems in menopause or other situations, subjective measures, so tests asking, are you having trouble with concentration? Are you having trouble with memory? Are you having trouble with switching tasks? Do a better job of tracking severity of symptoms and response to medications than these formal neuropsych tests. So part of it is that the neuropsych testing is done under highly artificial conditions. They want to precisely and narrowly measure a certain ability, but some of the setup of the laboratory situation is actually minimizing how someone may perform in real life activity. So for example, most of the laboratory situations minimize distractions. Most of them have a evaluator right there sort of helping keep you on track, whether it's consciously directing, usually not, but just their very presence is effective, just as we know having a clutter buddy or person there in the room can help someone with ADHD stay on task better. So, I mean, in confusing, so very often the neuropsych testing does little beyond what a thorough clinical evaluation does. I mean, so where it can be helpful, one is there's still lots of clinical evaluators who don't know that much about ADHD or separating it from autism or depression or bipolar disorder. So even though it may not be cost effective or the best approach, neuropsych testing may substantiate that there are problems in certain areas. So one point to make is that if neuropsych testing is revealing a deficit or a problem, that's probably something real important to pay attention to. The issue is that many people with ADHD are scoring within the normal range on many of these tests when in real life they seem to be impaired in that respect. where else might neuropsych? So I'd say sorting out diagnostic dilemmas. I mean, it may be helpful sorting out cases of autism versus ADHD, with dementia versus ADHD, with normal aging or with menopause and ADHD. Again, much of that you should be able to obtain through a good, thorough history rather than just the neuropsych testing. And we may be on the verge of developing more sophisticated neuropsych testing, or neuropsych testing that's more directly measuring EEG brain evoke, what's going on in the brain, not just whether someone's able to push a button or respond in that way. So there may be in the future more refined or more intimately tied to neural activation tests that may tell us more what's going on in the brain. Goosebumps. At what age should one stop using ADHD medication? A good question. All of these have been good questions, but that's one I haven't had frequently framed that way. And my answer, and I hope it doesn't sound flippant, is the age you should stop using ADHD medication is when it stops being effective, or maybe more precisely when the benefits fail to overcome any side effects or deficits someone's having. So there are clearly individuals who have been on ADHD medications, and not just medications, but stimulant medication for decades, 30 or 40 years. While there may be some increasing risk of cardiac effects, again, the majority of people, even after 10, 20 years on these drugs, the vast majority, like more than 95%, are not developing cardiac problems. Whether aging poses other additional risks. I mean, many people also frame ADHD medications as tools to help them perform in school or perform at work. And the important reminder is ADHD is a works across all spectrums of life. So sort of the argument for why you would take it or not take it on weekends, why wouldn't you want your weekend functioning, your social functioning to be optimal too? So some people think, oh, I've stopped working and I've retired, but actually retirement is one of the time points which drives people into treatment for ADHD, because up until that point, some individuals, particularly who grew up in an era where ADHD wasn't heard of or considered an option, found a job or partner and combination of those that worked optimally for them. And then when they face retirement and the complete lack of structure and active engagement that their job provided for them, they are lost and wandering and distracted and a nuisance to their partner. So again, I think something like age may be a general screening tool, and I have a talk on screening tools and written about that on Medium. Screening tools are just that. They are suggestions of paying more attention because of a certain score or result, or an age is a screening tool. I don't believe age should be a cutoff for our president. We have 100-year-old people who are completely of sound mind and pretty robust in their body. Go watch Dick Van Dyke dancing around at age 99. There's a video of him with Chris Martin from Coldplay. It came out, I think, in the last month. There are other individuals who are incompetent by the age of 50 or are never competent. So age, again, I think should be a screening tool and not an absolute cutoff for much of anything. So Harriet Louise is following up on the depression question. Stimulants improve depression symptoms, but yeah, so if the stimulant is helping with depression, then, and not executive function, I would say it's worth experimenting with dosage. It's also possible that there are pathways that are impaired or affected that just are not responsive to the neurochemicals we have right now to treat them. So there are clearly, at least, although there's considerable overlaps, at least certain separation of pathways between depression and ADHD. So Drop Neck asks, have I talked about thyroid problems and their treatment or the relationship with ADHD? Drop Neck just got diagnosed with hypothyroidism and started with levothyroxine, and I also take Concerta every day. So I've talked about it only in passing, so I don't have a separate talk on it. I think it's on my list of future talks eventually. So thyroid hormone, this is over caricaturizing, but the problems of thyroid can be too low hypothyroidism and too high hyperthyroidism. For many individuals with either low or completely no thyroid gland activity, replacement with thyroid levothyroxine, T4 and T3 combined sometimes can often completely replicate what the body was doing making thyroid hormone. There's also ways to suppress hyperactive thyroids if that's the case. And the oversimplification is if you're hyperthyroid, you tend to run hot body temperature, moving faster, hyperactive, hyper excitable, and hypothyroidism tends to lead towards sluggishness, thickening of skin, colder body temperatures. And either of those, so the hyperthyroidism can mimic some of the effects of hyperactive ADHD. The hypothyroidism can affect some of the executive function impairments or cognitive slowing in some people with inattentive and other forms of ADHD. So either way, there can be overlap in symptomatology. That's about all I don't know how extensively thyroid problems, given that many thyroid problems are autoimmune generated, and we know that almost every other autoimmune condition is more likely among those with ADHD than in the general population. My guess is that there's an association, but I have not looked at the actual data. So Harriet Louise asks, the relationship between ADHD and dementia and early dementia, what do we know? And I'd say it's a grossly understudied area and will receive much more attention as many more people get older and live to ages where dementia becomes more likely. One is, I'd say my important take-home message, there was a study last year, an Israeli study, I think the first author was Levin, and it proclaimed that ADHD increased the risk for developing dementia 5-fold. But what this study actually looked at was individuals over the age of 50 who had never had any ADHD diagnoses or substantial symptoms, who were developing new onset of executive function deficits, attention concentration problems. And then they followed those people over time, and a higher proportion than normal were winding up being diagnosed with who had ADHD, new onset ADHD in late adulthood, were winding up with a dementia diagnosis. I think and they acknowledged that part of their results may be part of this, but I think it was all of their results. I think all that they were measuring was early aspects of dementia can often look exactly like ADHD. So that's something we need to be aware of, that the big diagnostic point there is the time course. If you've had no executive function deficits and are developing them in your late 50s or more often 60s, 70s, and 80s, that's a huge tip-off. This is likely dementia. If you've had problems throughout your life, then it's probably ADHD, whether there's some people who there's limited data as to whether childhood ADHD increases the risk for dementia. There's some evidence that actually it may do the opposite. It may protect against it, given that some aspects of ADHD represent slower maturation, less effective pruning and elimination of possibly redundant pathways, but that may provide some cognitive reserve. So the other big issue with dementia research or dementia clinically, you go on the internet and there's hundreds of products that claim they can prevent dementia, and self-help advice that if you exercise, if you learn French, assuming you were growing up speaking French, learn a second language, if you play bridge, if you're socially active, you can prevent dementia. And what most of those studies are actually showing is that you are delaying the onset of dementia. Now, practically, that is great. Every year you live with the brain in a better condition. That's wonderful. But that's very different than really interfering with the disease process. We're just interfering with how soon it manifests in the given brain. So again, I do have a video on dementia and ADHD, and hopefully we will get more concrete information going forward. TLISU asks, could a case be made for integrating amantadine or memantine if a person experiences quick tolerance build up to their stimulant medication? So I do have a talk on amantadine on this channel. So amantadine originally is a drug that was used to treat influenza virus. It was one of the very first antiviral medications. It was found when they were treating a group of elderly people with it prevents influenza and can treat it when it's there, influenza type A. A group of Parkinson patients who were treated with it for influenza wound up having an improvement in their Parkinson symptoms. It was found, and it's probably an indirect effect, to boost dopamine, which is dopamine cells are what's damaged and deficient in people with Parkinson's, a movement disorder that also can have neuropsychiatric manifestations. And amantadine became a mainstay of Parkinson treatment for boosting dopamine. It's used in a few other things. Again, it's probably having more direct effects on glutamate, also has anti-inflammatory effects. There are certainly clinically a number of people who are using it in combination with a stimulant medication, and I'm not aware of any studies that clearly show an advantage to the combination, but as I talked in my combination study or video, we have very few studies specifically looking at combination treatments. So Harriet Louise is cheerleading for me. Thanks. She mentions YouTube will push live streams more if they have a good ratio of likes to viewers. So please give a thumbs up to the stream to help. I appreciate that. Modima Rose, I'm glad you're addressing the menopause aspect in effective treatment. Bear Jobs asks, how do I like the live stream? I've worked clinically with people for 30 years. Although a lot of my practice has been adults with ADHD, I've certainly worked with a lot of adults with depression, panic, PTSD, anxiety disorders, social anxiety, just leaving off something significant, borderline personality disorder. I know I've helped a handful of people tremendously in their lives, but I felt that I had knowledge and information that would be more useful helping a lot of people a little bit rather than helping a few people a big amount. I think both are good and worthwhile things to be doing. So I see this as a wonderful opportunity to reach bigger numbers of people and help them maybe just a little bit in their life. The questions I'm getting, I think, are well thought out, pertinent to lots of individuals and interesting. So I'm enjoying that aspect of it. There are some frustrations with the sound and the recording. I'm not technologically expert at all. I'm getting excellent help from Max in Paris for the last half year now. And I think hopefully things will continue to grow. I'm worried if they grow too much, whether I'll be able to keep up with questions and such. And I'll overly share. And since part of my whole approach is to be always nuanced and always when people, I'm not a glass half empty, I'm not a glass half full, I'm both. It's both. Look at both and put that in context and appreciate the good, be aware of the bad. So the bad is, I think, there, as people pointed out in the comments, there's Russell Barkley and a few other thought leaders have put out lots of good content about ADHD. There's a few other non-clinicians who experientially, and I'm forgetting her name, but How to ADHD, I've enjoyed and think her information is informative. And there's also a lot of garbage about ADHD out there. So hopefully the stuff that's true and informative keeps getting more attention and spreads awareness and understanding. So maybe I overanswered that. So the other downside of the Q&A is that I am dependent on Elon Musk's Starlink system. I'm in a rural part of Hawaii, so separate from the individual sound aspects of the room, my microphone, the setup here, there's issues of lag and continuity, and if it continues to be suboptimal, Max has thought out a way that we could make it a Zoom Livestream as a Zoom, but it would have to be through him where he has a better continuity connection. So thanks, Chris, who mentioned that audio is good today. So we have made adjustments, and I'm glad that it's showing up. And again, I'm glad Elon is behaving today. So Gutek 252, hello again, and I'm recognizing many of you from throwing in questions before. Is Elvance safer than Ritalin? So Elvance in the US is called Vyvanse. It's lisdexamphetamine. It's lysine linked to the amphetamine molecule. The lysine needs to be cleaved by the red blood cells, so there's a slow delivery system, and it's harder to abuse it. But in in terms of safety, the issues that come up comparing amphetamine products versus Ritalin methylphenidate products is cardiac safety, addiction risk, and psychosis risk. Cardiac risk with either form of stimulant, it's going to be dose dependent. And again, most people are having meaninglessly tiny changes in heart rate or blood pressure, a smaller percentage, but even at 10, 15 years out, it's less than 4 or 5% of individuals. And again, that's not 4 or 5 times the rate of the background rate. That is the rate. So the background rate is not negligible. So I'm not aware of clear evidence that there's a difference between the two in terms of cardiac risk. There's some suggestive evidence that abuse potential is higher with amphetamine products than Ritalin. Maybe the slow release forms like Vyvanse are lower risk. And again, to put that whole abuse potential in context, substance abuse problems are really high in the US and other westernized countries. Something like 20, 25% of the population in any given year. People with ADHD have almost twice that risk overall, and being on a stimulant, particularly starting it in childhood, seems to reduce that risk to the background rate. So the one risk that I think our field still under promotes is the risk of psychosis. I do have a video on that. And the growing evidence is that amphetamine-based products have a risk in the range of somewhere 1 out of 500 to 600 people. It does seem some scant evidence suggests it's dose. The higher the dose, the greater the risk. And the risk with Ritalin in studies conducted with similar epidemiologic and experimental designs don't find that risk. So in that respect, Vyvanse, Elvance would be less safe than Ritalin. The one area I think there is some data suggesting actually an advantage of amphetamine drugs, and this is also highly partial and incomplete and needs better studies, but we're never going to do the optimal studies, which is in pregnancy. And there, in general, most women are not having problems during pregnancy, or their developing fetuses are not showing problems, but rarely there are some problems, and those rare problems do seem somewhat higher with Ritalin than with methylphenidate and amphetamine. That's very preliminary, and we may get more extensive data that changes that. And again, overall, both tend to be not high-risk medications. So Dennis asks, is social anxiety disorder a cyclic condition? So given that most individuals have social anxiety in the context of particular situations, so I don't know whether you, so that makes it harder to evaluate. So in that the specifics of the situation matter, and most people are not on a completely regular intervals exposed to the same social conditions. So whether it waxes and wanes completely separate from exposure to the social context, I'd say it's not widely discussed or talked about as a cyclic condition in that way. But I would say clinically, I certainly see people who, when other anxieties or worries or stress in their life are apparent, may be more affected by their social anxiety in the same situations that were only mildly evocative in the past. So that's probably the best I can say. TLISU is, how would we work with individuals who experience dramatic decrease in the effectiveness of their stimulant medications when they eat or drink anything other than water? Thinking about urinary pH. So I do have a whole topic on acidification and pH and how that affects stimulant medications. A dramatic approach would be not eating or drinking those substances. Usually if it's affecting absorption, and usually excretion is to a smaller extent. With absorption, it should be only food or drink that they're consuming within about an hour of consuming the medication. If it really clearly seems to be that they're changing urinary pH and that's affecting elimination of the medication, then I guess you could work on taking other substances that would not lower the pH, but raise so low pH is acidic, raising the pH. So it might be worth exploring foods. I don't think anyone's going to start munching on baking soda. That would do it. My thought was I would be looking for additional factors and or even psychological components to see if those are having an effect. So again, there are good, valid physiologic reasons. There are going to be people who are more sensitive to pH effects, but usually it's not that dramatic effect. So again, I'll make another plug. So again, Max has set up a subreddit. It's under Dr. John Kruse, DrJohn KRUSE at Reddit. If any people use that or find that that's a better forum for posting questions that you can answer for each other or try to answer for each other or pose for me or pose, and again, that may be a more consistent repository, because some people have mentioned that when they typed in questions in advance here, they disappeared from the chat or the questionnaire. So Modima Rose asks whether Cymbalta and stimulants increase the risk of psychosis, whereas stimulants and Prozac did not. Any thoughts? I'm not aware of that specific data. So if you have reference to a specific study, I'd be delighted to look at that. I would. it would surprise me because the difference between Cymbalta and an SSRI like Prozac is that it's having norepinephrine reuptake action, which is not strongly, it's thought more often that dopamine involvement is going to be more directly causative with psychosis. So it's reporting personal experience. So one is asking what do you mean by psychosis? So some people use it imprecisely to mean more agitation, revved up, out of sorts, highly distressed, and certainly Cymbalta is more likely because it's boosting norepinephrine to cause some of that than SSRIs are. But in terms of formal psychosis, which involves loss of contact with reality, can be derealization, can be depersonalization, it can be usually some amount of delusions and or hallucinations. Those can happen with any substance prescription or not, but usually it's extremely rare occurrence. Why we're studying it more often now is because it is something associated particularly with THC and marijuana. Again, it's not a common occurrence. It's not the 1950s reefer madness that everyone who takes a toke becomes psychotic, but it's also not just a fake or media generated occurrence. There clearly are some people probably who have some genetic predisposition. Whether all of them would have become schizophrenic anyway seems unlikely, who develop psychosis with marijuana. Again, it's a known side effect with stimulants, but particularly with amphetamine. So Richard asks, what are the differences between autism and schizoid personality disorder? So I will say that my answer to this will be as a general psychiatrist and not someone who professes to have particular expertise in either of those. What I would say, and I know that some people on the autism spectrum don't like that I am more conservative in sort of sticking to, so that the cornerstones of an autism diagnosis involve difficulties with processing social information. So it's not just anxiety or discomfort in social situations. And it's, most classically by eye direction difference. So most little babies look at people's eyes. Children on the more severe end of the autism spectrum are not showing a preference for looking at people's eyes. They're not processing social information in the same way. It's not that they're processing it and don't like it or find it aversive, although maybe at that milder end of the spectrum, that may be more how it's experienced. So social avoidance, repetitive, what are called stereotypical behaviors, so flapping hands, other rocking, head banging movements that are repeated in the same motion over and over, particularly times of distress, and certain interests that are highly narrow and sort of often superficially focused on intricacies or details without penetrating to the, so it's like memorizing train timetables without really having any grasp of the city or where these trains are going to or what they're doing or what the subway system or train system is like. So one is autism is usually defined as a neurodevelopmental condition, and usually it's showing up very early in life, even though parents may not be cued into delays and differences until age 2 or 3, which is about the time when people are getting lots of vaccines. So often they are misattributing, oh, kid just got a vaccine and now they're looking weird, when looking back, most of these kids you can demonstrate were showing aberrations before they got their vaccines, and extensive epidemiologic studies has not found a connection between vaccines and autism. So autism, again, defined as a developmental early life process, whereas schizoid personality disorder, which is different than schizotypal. So schizotypal is a personality disorder. So by definition, personality disorders aren't usually diagnosed till late adolescence or even young adulthood. They are pervasive problems of interacting with other people. With schizotypal, it's patterns that look a little bit like schizophrenia. So delusions, paranoia, sometimes hallucinations, derealization, depersonalization, but to a less pervasive or disruptive extent than full-blown schizophrenia. Schizoidal is more focusing on what we call the negative aspects of schizophrenia, so the lack of engagement or interaction with others, flattened mood, lower motivation. So again, some of the big differences would just be the developmental ones. So Modima Rose, jumping back to the psychosis and stimulant plus or minus Cymbalta or an SSRI, acknowledges that there may have been stress or situational factors going on. So Gutek 252 says there's a drug in my country containing 75 micrograms of clonidine. It is prescribed for hypertension. Would it have any effect on ADHD, or is it better to try methylphenidate first? So in the US, so clonidine, again, a very different drug than Klonopin, which is a benzodiazepine. So clonidine is an alpha-2 agonist. So like guanfacine, an alpha-2 agonist, both of these, so they're acting on a subset of the norepinephrine. So adrenergic is norepinephrine system. They're working on a subset of the norepinephrine system. They actually are both approved and work for lowering blood pressure. And one of the big differences is how quickly they leave the receptor when they're done. So clonidine leaves the receptor very quickly. So some people taking it for blood pressure who miss a dose or stop at cold turkey have a rebound increase in blood pressure and an increase to levels way higher than their original hypertension. So it can create a hypertonic emergency, high blood pressure emergency, hypertensive emergency, sorry. Guanfacine theoretically could do the same, but when they've conducted experiments and tried to find out clinically how often does this happen, it seems to be a much rarer possibility with guanfacine. So guanfacine also is effective in treating ADHD, and it's an FDA-approved medication, and it's approved as the slow-release form. Intuniv is the brand. But the first studies on alpha-2 agonists and ADHD were done with clonidine. So 75 micrograms rather than milligrams seems like quite a low dose. I'm, again, not quite as familiar with clonidine. With guanfacine, the dosages are usually in the 1 to 4 milligrams that are tested. So milligrams, again, are 1,000 times bigger than micrograms. But I would anticipate that dosages of clonidine that are effective for hypertension should be helpful for some people with ADHD. That the big reminder is that unlike the stimulants and unlike many of the non-stimulants that have immediate effects on boosting either dopamine or norepinephrine, most of the evidence with guanfacine suggests it's a slow, indirect effect, and that good work by Amy Arnsten and other colleagues has indicated that most of what it's probably doing is strengthening and building and strengthening synaptic connections in the prefrontal cortex. The alpha-2A receptors are largely on neurons that are receiving glutamate input, so it's modulating how the brain is processing those glutamate signals. And again, those are slow effects that take a while to develop. So it would be usually only after 2, 4, 6 weeks on guanfacine that you'd see improvement with ADHD. I do need to go before 10 to a little, or 11 Hawaii. Actually, California time is what my computer is still set at. So I still have about 15 minutes, but I need to be conscious of that. Michael James asks, how do you assess the efficacy of cerebellum-focused exercises for dealing with executive function deficits of ADHD? So one of my future talks, and I have not, so the cerebellum is not an area I pretend to have expertise on. There's certainly studies showing involvement of cerebellum tracks or pathways on ADHD. One of, I guess what I would say, without knowing intimately which studies or research we're talking about, is that many of the neurofeedback-based claims about what they are training or eliciting or focusing on may indeed be accurate and focusing and eliciting activity or dampening activity in the structure they are targeting. But most often they're not checking systematically to see what else they're doing or not doing. So it makes it a very weak claim that even if they find results, that they are actually due to cerebellum-based interventions. So I think I'm going to leave it at that. I guess I do have a PhD in neuroscience. I do think the brain is important, but I think we are often jumping to bigger conclusions than we should be making based on small studies and based on not looking at what else is going on in the rest of the brain. And we do that both in a neurochemical basis, which is, again, much of what I'm talking about in that norepinephrine and dopamine stories video. But we also do it in a network. I mean, we also tend to frame networks as these almost little cassettes you can switch in and flip in and out of the brain, like the plastic models of the brain. And the thing to remember is that each of our neurons is probably receiving input from hundreds or a few thousand other neurons. So the brain is much fuzzier. It's much more interconnected. Yes, there are real pathways, but there's also all those cells are probably receiving lots of other additional input and sending input to other directions that we're not accounting for, or that numerically are less strong or robust, but almost certainly brains wouldn't have evolved this way if they weren't doing something. So Mother Nature isn't putting in things just to be wasteful or redundant. So Dennis asks, is being able to read before the age of 4 a bad sign? A functional neurologist who specializes in autism said no one should be able to read before age 4. That to me is baffling. I mean, it sounds to me that they're trying to be provocative with clearly lots of very highly intelligent, highly functional individuals have learned to read before the age of 4. And usually, so lexical strengths or abilities or language are not going to be excellence in that area is not likely to be interfering with functioning in other areas of the brain, and are probably almost certainly providing greater cognitive reserve in case of other problems or difficulties. So they may know more than I do regarding their expertise in autism, but to me, that sounds like they're just trying to be provocative, and I think their point is actually off base. So, from everything I know. So, hello, Jonathan Carpenter. I'm having a good day. I hope you are too. So, Gutek 252 says this, so it takes time to see the effects of non-stimulants, just like atomoxetine. So that's one of my biggest pet peeves. I'd say, no. Guanfacine works slowly and indirectly. So guanfacine does work slowly. But atomoxetine, bupropion, Wellbutrin, Cymbalta, duloxetine, all of which have either direct dopamine or norepinephrine reuptake capabilities. So immediately means within minutes to hours of taking them, you are making more norepinephrine or norepinephrine and dopamine available, which is what stimulants, which is what methylphenidate does. So at a neuroscience basis, you would expect most of our non-stimulants to work immediately. And if you actually talk to people clinically, you will see, I've gotten testimonials because so many experts claim the opposite. So I have individuals who say, took the Wellbutrin, could tell right away within an hour that this was working for my ADHD. Took the Cymbalta, could tell, I was taking it for depression. I wasn't even focused on my ADHD, but I was aware I was processing things differently. I think part of the problem or the confusion, so what these ADHD experts have said is that stimulants work directly and quickly because they're boosting norepinephrine and dopamine. But these other drugs are like antidepressants, and we know antidepressants take a long time to work. Those are valid so far, but a drug can work by different mechanisms. So when Wellbutrin works slowly for depression, even in people it's working slowly for depression, most of those people are feeling more energetic within a day or two, more alert within a day or two. The mood effects are slower and indirect. The problem is atomoxetine, Strattera, the very first non-stimulant approved for ADHD, is a drug most people don't tolerate. Some people do well by it. I have a whole talk on this. I'm not going to go into it in excessive length, but maybe more than anyone wants right now. Most people need to start out on a very low dose of a non-therapeutic dose of atomoxetine. They need to build up to it over the course of weeks. And then at 5, 6, 8 weeks, when they're at a therapeutic dose, the tests are registering, it's having some beneficial effects for ADHD. That doesn't mean it was a delayed effect. It means it took a long period of time to get up to a therapeutic dose, is my interpretation. And I have worked with some people who, immediately took a large dose of Strattera and tolerated it and had immediate effects from that. So I think the problems with Strattera have contaminated or introduced this thought that all non-stimulants take a long time to work for ADHD. Again, it does not make sense at a basic science point of view, and it does not make sense from a clinical point of view. And to me, it suggests that many of these ADHD experts may not even be either talking to that many patients, or they may just be assuming if they see someone 4 weeks later after they started them on bupropion and that their ADHD is doing better, they're just assuming it's only doing better in the last week or two rather than ascertaining that it improved from day one. So Rut H, how does someone tell when atomoxetine is working? So jumping back to not quite neuropsychological testing, but ADHD scales are one of the most useful places for ADHD scales, which usually have 18 questions and asking, are you bothered a lot today by distraction only a little bit or not at all? So usually have a couple different ratings. So ADHD patient rating scales are a good way of recording now what your performance is before taking something like atomoxetine and checking at weekly intervals or to see if there's any trend towards improvement. Again, even though these scales are designed and lots of intelligent people put lots of thought into these, they're designed to be monitoring severity of ADHD. They are not immune from if someone gets depressed or if someone gets freaked out by bad election results or there's a tornado or a flood or a wildfire in their area that completely disrupts their life. That's likely to show up on aspects of distractibility and attention and maybe even impulsivity. So the other alternative to formal testing is I often recommend that people try to come up with quasi-objective monitors. And this, to me, was easier in the pre-internet age when people would read newspapers every day. Or once a week, you'd read the Sunday New York Times. And if you got so distracted bouncing from article to article that it took you 2 hours to get through the New York Times, but now on your medication, you can read the whole thing, or the whole thing being what you really want to read in an hour, that's a good measure. Or if you, in the modern era, if every day you go into work and you resolve, I'm going to check my emails and then get started on work, and you get so bogged down and distracted and bouncing around with your emails that it's an hour and a half before you really start work. But now on your Vyvanse or your atomoxetine or whatever else you're taking, you can actually check off the pertinent emails in 20 minutes and move on to work. That would be a quasi-objective measure of improvement. The other thing it highlights is that most of the time, if someone has a substantial benefit from a medication, they can detect it. On the other hand, part of ADHD is being less attentive to things in life, including attentive to your own attentiveness. So there are some situations in which people are actually improving, but part of their improvement in executive functions is now that they are more aware of every instance that they are off track or doing something wrong, and their impression is they've gotten worse when they've really gotten better. So getting feedback from partners, teachers, coworkers, if you're comfortable, friends, is often valuable in assessing how well ADHD medications are working. Yep, so Gutek 252 mentions feeling depressed for the first 2 weeks on Wellbutrin. So there's no drug that works for everybody, and it's important to pay attention to individual responses. So I have about 2 minutes. Root H said I took atomoxetine for a couple of years and didn't feel much of anything, pretty much stayed at 60 milligrams, but then I tried 80. I'd end up forgetting a pill or something and end up giving it up. So hopefully with cognitive behavioral approaches to there are strategies for reducing the likelihood of forgetting pills, particularly tying it into other habits, having pill boxes. And I tell even people just with depression in their 20s, the pill looks the same every day. It tastes the same every day. It smells the same every day. Why the heck, 20 minutes later, would you remember whether you took it or not? So pill boxes where each day of the week the pill's there, you know whether you took it or not, are helpful, not just for the elderly with dementia, but for at any age or individual. So I'm gonna wish you all happy day. Stay healthy, stay happy. If any questions come in as I'm sort of wrapping up, I will write them down and try to get back to them next week. So I will be on Christmas Eve, the 24th, and the 31st. I guess that is New Year's Eve as well, at the same time. Certainly, if you want to take a break and enjoy yourselves, I heartily endorse that. So I will be here regardless of the size of the crowd. And I thought I had set up the live streaming so you could write questions ahead of time. I could not find it. So if I do ever find it and there were questions posed there, I will try to address those. And I will also try to figure out whether I just hadn't set it up or whether I deleted it or whether I couldn't find it, what's going on. So thank you all. It's been a pleasure, and stay healthy, stay happy, and I'll be back next week.